Yes. Okay. Thanks, everyone. I, too, as Ruby did, kind of just went through the template that we were given. So I actually don't have a lot of slides, but I'll talk to that. Interestingly enough, aged care, there actually is some evidence base behind implementation, which is a bit strange because aged care often falls behind the curve. However, in 2015, in America, long-term care facilities that were receiving Medicaid funding were required to implement antimicrobial stewardship in their facilities. So as a result of that, the CDC has put out 7 core elements of antimicrobial stewardship in long-term care. And also since then, the National Quality Partners, an agency for healthcare research, have also come up with tools and resources to help long-term care facilities implement AMS activities. Since then, in 2017, this has been further refined, and there's actually some very specific things that they recommend now. So they recommend the inclusion of an ID specialist, multidisciplinary education, tools integrated into nursing workflow, and tools that facilitate prescriber review of antimicrobials. Whereas another author did a similar review, and he concluded that AMS implementation and activities should have practice patterns based on established diagnostic criteria, proactive infection prevention, and open communication among staff. With all that work that's been done earlier this year, there was another analysis that was done in the literature, which actually said that there is nothing that we can yet recommend for implementation in long-term care facilities yet. And there's also a serious publication bias in the literature. So they're publishing things which had positive outcomes, and so there's some worry there as well. How this relates to the Australian situation as well is a bit tricky, because aged care home policy and government has at least 2 streams involved. So there's the famous accreditation standards, and that comes from the Aged Care Quality and Safety Commission. And that is really the policy and the governance for the administration, the nursing staff, the personal care assistants on the homes itself. But then all the antimicrobial prescribing is done by those visiting GPs. So all those issues that Leslie and Ruby just brought to the forefront also apply in aged care as well. In addition, aged care homes, there might also be an additional organizational wide policies and governance. And when I talk about our implementation, that's actually where the implementation came from. It came from the organization-wide policies. So the tricky thing is that the traditional medical model hierarchies places the authority, of course, of the medical staff above the nurses and other staff. And like I said, it's the visiting GPs are the ones doing the prescribing. However, it's the responsibility of meeting those accreditation standards largely rests with the nursing and the administration. So that's why you do get recommendations about putting tools within the nursing workflow, concentrating on what the nurses are doing, rather than having a look directly at what the GPs are doing and the doctors are doing within the aged care homes themselves. But there can develop this tension within the aged care homes themselves. I should just pause and say that the accreditation standards for Australian aged care homes this year, as of July 1st, do have an AMS standard that they do have to meet. They have to have policies and procedures which promote appropriate antibiotic prescribing. They also have new infection control standards as well. I haven't yet heard any feedback from people who have undergone those accreditation reviews sort of between July, so it's all very new. What I have heard anecdotally from different places is that they kind of aren't quite sure what that is going to mean for them as well. We also have the ACNABS, which is the Aged Care National Antimicrobial Prescribing Survey, so there is really good data now on antimicrobial use in Australian aged care homes. Depending what year you're looking at, and depending on how you're judging it, it's usually around 50%, but can vary between 25 and 75% of appropriateness for antibiotic use in aged care homes. So this was the project that we did. It was done as what we call a pilot pragmatic implementation. And what it was, the justification for it was that antibacterials are beneficial for bacterial infections, but they're unlikely to provide benefit for residents with a viral respiratory tract infection. So the identification of respiratory virus can, in many instances, allow for the cessation of unnecessary antibacterials and trigger infection prevention measures. So tools to assist with the accurate diagnosis of viral respiratory tract infections would thought to improve the appropriateness of antimicrobial prescribing. The key stakeholders and their roles, the nurses, as we said, are important conductors of antimicrobial use in aged care, and they were the ones that we trained to take these swabs. And there were several reasons why we did that. And again, with the governance structure of aged care, it can be quite tricky. It is the nursing staff that usually has the responsibility for infection prevention and control oversight within the aged care home. And anecdotally, within these homes, we had data which suggested that the visiting GPs were not taking these swabs. So we asked the nurses and trained the nurses to be the ones who initiated the swab. Incidentally, we started this in 2015, and that was actually before those recommendations for implementation came out. But our implementation actually hit on all the recommendations that they suggested. So inclusion of an ID specialist, we had the ID specialist physician who was overseeing it at the aged care homes. We had multidisciplinary education, so for the nurses, for the GPs. We had tools integrated into the nursing workflow. So again, we asked the nurses to be the one who are taking these swabs. We had tools that facilitated prescriber review of antimicrobials. So when the prescriber came back, the result of the swab came back, reviewed what the result is. If it's a virus and you're actually on an antibacterial, you would look at the appropriateness of that prescribing. And then we also had established diagnostic criteria and proactive infection prevention. And we tried to facilitate this open communication among the staff at the aged care homes. When we set up the implementation, we did have the evaluation framework, which included both the quantitative outcomes. So the original study was a before and after study. So we were looking at numbers of antibiotics prescribed per infection in the 12 months prior to the implementation and then the 12 months during the implementation. We had a record of all the respiratory tract infection specimens taken, what the results of any laboratory and diagnostic reporting was, any adverse events, and any refusals of the swabs themselves. Any other actions taken by the GPs and nurses with regarding antibiotics, as well as any transfer to hospital or any adverse events which may have occurred. And resident outcomes, including unattended consequences, were looked at as well. In aged care homes, you also have a number of key stakeholders, not just the nurses and the GPs and in and of themselves. The residents are often clinically complex, and the part of our study protocol, we met with the residents and we talked to the residents and we explained what's happened with the swab and why we were doing what we were doing. And again, the families as well. And there was a little bit of pushback or hesitation by the families when we first talked to them about it. I think families in aged care tend to be hesitant, they tend to be cautious. But there were a couple of calls just asking for further information from the families when we started. And of course, the residents and the families needed to provide their consent as they would for any other diagnostic procedure. So we set out to do this. Again, the first study was in 3 homes. It was over 12 months before and after. The second study added another 4 homes onto that. So we ended up with a total pool of 7 homes. What we found out was that I would say that we did successfully manage to implement the PCR testing. So we had over 50% of the recognized respiratory tract infections were in fact initiated the swabbing by the nurses. But what happened was that we didn't have the flow-on effect of the antibacterial discontinuation. Through our outcome measures, we did find that the GPs were responding to the swabs. So despite some hesitation, I would say that the GPs at best were, I will say, neutral about the idea. I'd say at the worst, we did get some pushback from the GPs. Our data and our evaluation shows that they were responding, but they were only responding to the swabs which are positive for influenza, and their responding by prescribing oseltamivir for influenza and not by discontinuing antibacterials. Other, quality measures that we looked at were such as things as initiation of infection control interventions. What we found as well is that the swabs were useful in doing that. So in conclusion, despite having all those elements that were recommended, and despite having what I would say was a successful implementation where over 50% of the respiratory tract infections were swabbed, we did not have a successful intervention in actually reducing the number of antibacterials or the number of inappropriate antibacterials for that matter in the intervention. These are all the funders and the people who helped with the program. So I'm going to add to the literature that's out there about publication bias, and I will add my publication to the literature, which actually showed that in this case it didn't have the effect that we were working despite having what I would consider to be a successful intervention.
So what's the next study?
Oh, that's a good question.